All right, it's time to get started with this thing. Can you hear me all right, Chad?
Yes.
Okay, so welcome everybody to our clinical faculty development series. We're thrilled to have Dr. Chad Hood here talking about acting internships today. And with that, I'm going to turn it over to him so that way he can have all the time that he needs to talk.
Thank you. I'm currently the sub-I director or AI director at University of Florida for internal medicine. Internal medicine is my background. There are some slides here at the beginning. Dr. Beck Dallahan can guide me, but I imagine these are standard. They were in the template, I
Yeah.
guess potentially for folks who may be joining anew, but otherwise this is probably fairly familiar to you from other iterations of this really great series. That's based on the guidebook for clerkship directors. Talk about that in a second. These are the former series for which recordings are available on the website, and then these are the current, and you are here for this one right here. This is the guidebook for clerkship directors. I think I saw our fearless editor, Dr. Morgenstern. I think I saw him on the participant list. And the chapter that I wrote, co-wrote, I should say, fittingly for this topic was about acting internships with Sandy Sanguino from Northwestern Feinberg School of Medicine from a pediatrics perspective. I guess I should also mention I've been a sub-I director for 12 years, and we have a few programs, 4 different choices in the core specialties to choose your AI from. But about 75% typically do medicine. And so that means I did some math and it came out to over 1,000 students that I've probably worked with and worked with on the sub-internship. I also, when I interview people for internal medicine residency, I always ask them about their AI experience, and it's extremely variable around the country about what people are able to do, from sometimes even what sounds like shadowing experiences to full immersion, which is kind of what we prefer. So this is something I care about a lot. If I have the opportunity to advise the group, I would consider that a wonderful honor and privilege, and happy to be here. These are the objectives. Not everyone here is a sub-I director or an AI director. Some of you are probably not even clerkship directors, and the audience. I would say that third bullet, though, is hopefully of broader interest to all audience members about things that we can do in the curriculum, wherever it might be. In this case, it's during the AI rotation to strengthen student preparedness for residency. But I am going to look at 3 specialties for which I was able to find curricula for the sub-I: medicine, peds, and family medicine. And then we'll also talk about the core EPAs for entering residency, probably a topic that this group has already heard about. That tends to be more of a focus for those of us working in 4th year education, but that's definitely a strong role to incorporate. And then options, this is maybe more for folks who are actually truly AI or sub-I directors. I didn't set up polls due to very poor planning on my part. But if we have time at the end, I would like to hear from people about different ways that if you are a sub-I director or have former experience with that, what you're doing, especially in the area of evaluations, grades, and a couple other topics. I don't have any disclosures that I'm aware of that I need to share, other than I probably should disclose that there will be New Yorker cartoons in the presentation. I do this just because we've got some really weird sayings in medicine, and sometimes we mean one thing, say another thing. Sometimes we mean exactly what we say, but it kind of opens the door that in this case in particular, we really need to talk about terminology. So is it an acting internship or is it a sub-internship? Well, it turns out it doesn't matter. After looking at probably 100 different articles in preparation for this talk, there's no study about the value of one versus the other or the prevalence of one versus the other. They're essentially synonymous. And I apologize if this is repetitious to those of you who know it, but the sub-internship is in the literature more and in the websites more, from what I've seen. And I think that's because of the historical connotations. So subinternship was a term that was developed in World War II when, because of physician shortages, senior medical students were kind of elevated into these sub-intern roles. It was really very much out of necessity, not out of academic virtue or rigor. And and then after World War II, it became predominant and widespread and spread into multiple other specialties and subspecialties. So I think that historic reason may be the reason why in the literature the term subinternship is used a lot more. I inherited the term subinternship at UF, but I'm actually working this year to try to change it to acting internship. And it may be semantics, it is semantics, I guess, but I occasionally have a student who the resident will relegate to an intern to work with. And something that's going to come up in this talk is that that creates a lot of problems, because you'll see some of the key features from the different specialties about for an acting intern is that she or he needs to have primary responsibility for the patient and therefore it needs to report directly to the resident and function like an intern on the team. So you could see how maybe the term sub-intern might imply working with or below an intern, whereas the term acting intern, it's very clear what that person's role is on the team. And then there's getting into the context, the type of AI. This is from 2014, and the authors here, Dr. Elnicki and some other folks, two of the members, Susan Gallagher and Martin Muntz, I just want to mention their name. I don't know them. I didn't look quickly to see if they might be on here, but they went to all 136 web pages for the 136 LCME accredited medical schools. This was in 2014, and looked at all of their fourth year curriculum to see, and some kind of an acting internship is required at that time at 90% of schools. That tends to hold pretty true from what I've seen more recently published. 10%, it was only they had no other option other than medicine. You get a little bit more when you start to get into doing an AI in the core clerkships like peds, family med, surge. But already, even in 2014, most schools had 4 or more choices. And I would say that's probably even higher just from what I've seen at websites and things like that. There were even some that require you to do 2 acting internships. And of those that did, the majority of them, 17% out of that 20%, required that one of them be in medicine and the other one be in something else. I should mention that Yale has 32 sub-internships. And that's something we're going to talk about later in terms of how that might guide curriculum choices. I want to talk quickly about just the relevance. So program directors, this article, I think there it is, surveyed. Now it was from one school, I think it was University of California, San Francisco, but they looked at the schools that their students matched in, and they looked at the specialties that their students matched in and reached out to those PDs, and maybe a little bit of a regional bias there. But ask them what things do you value in the fourth year, and specifically about the role of an acting internship. And not surprisingly, overwhelmingly, they all said, well, you should at least do an AI in your specialty. And kind of surprised that 50% of them said you should do it in medicine. And I don't know if they meant in addition, and that 50% in medicine wasn't just the medicine and the core clerkships. They included a fair number of program directors from procedure-based fields and subspecialty-based fields. And even 50% of those said that you should do an AI in medicine to get some sort of core backbone of skills. Okay, then student preferences. This is again one program. This is Boston University, but I think it's fairly indicative of where med students' head are. They asked them to look at 20 tasks, and did they feel that fourth year, and then also specifically the acting internship in particular, did it prepare them for those 20 tasks? So pretty high score just from the AI itself. Now, interestingly, just for this audience, I thought I would share, here are the things they said nowhere in the curriculum did they get, I'm sorry, they felt poorly prepared. And some of you may be at schools where you already specifically focus on breaking bad news or decision-making capacity and things like that. But I thought it was interesting as a potential future area of focus for a fourth-year curriculum or otherwise. So in terms of curriculum, I mentioned Yale. So when I read that Yale had 32 different acting internships, like, well, some of those are just electives, right? And they have 14 different surgical and sub-internships. They call them sub-internships, by the way. They have 5 different GYN, including oncology, maternal fetal medicine. The there's a lot of sense that really we just need an experiential curriculum. I saw that term come up quite a bit, talking about what the fourth year should be like. That you're learning how to be on an intern, learning how to, and the best way to do that is on your feet, to be out there on the wards or in the operating room or whatever it was. So maybe you could kind of do that in an elective. But I really like what Yale did here is they said, if we're going to try to truly build these people to be involved at the acting intern level, they said, well, okay, first of all, you've got to have this primary patient care responsibility. This is a term that's going to come up over and over in this slide set, as opposed to just kind of working as an adjunct to the resident or to the fellow or maybe even the intern. And you're going to be regularly and directly interfacing with team members. You're going to be totally immersed in their care, all aspects, start to finish, and even sometimes beyond in terms of post-discharge care. And as opposed to just kind of a case mix that's very specialized, you can have a broad case mix, but more importantly, that you need to have a case assignment and a patient load that's approaching what a first-year resident within that specialty would be able to manage. Now, in a subspecialty, that number might be lower, but still the idea is you're not really shielding your sub-I from any kind of, you're really trying to help get them immersed into an acting intern role. It's also an opportunity to kind of build on your clinical knowledge, the professionalism, things like organizational skills. That's something that's going to come up a little bit later. Time management, asking for help, and things like that. So I thought that was a good starting point to think, what's the difference between an AI and other kinds of rotations? So next I want to look at the first of those 3 programs, look at internal medicine and what curriculum they have recommended. This article took a group of clerkship directors in internal medicine and linked them with residency program directors, the APTM part, residency program directors in internal medicine, with a specific focus on a committee on transitions to internship. Cacti was the name of the group. I was actually fortunate enough to be involved in this group. And this whole idea of now more important than ever wasn't my idea. It wasn't just self-aggrandizing, but I support it. And the more important than ever really had to do with the timing of this article. This article came out in 2015. And there already was an existing internal medicine curriculum from clerkship directors, IM, CDIM, from that professional society that had come up not too long before this. Then in 2010, they did this very extensive survey of program directors. Now, granted, it was internal medicine, but pretty extensive, and created a huge amount of data in terms of what do program directors value in terms of the sub-I, the acting internship experience. We're going to look at that survey in just a minute. And then 2014, AAMC released the core EPAs for entering residency, 13 core EPAs that all medical students would be expected to have some level of independence in before entering residency. And we'll look at that as well. So kind of the alignment of these 3 things made for the perfect timing of the publication of this article. The program director was survey was pretty big, 36 items. They got a really good response, 75% from program directors, a huge amount of data. But interestingly, by the way, they also let the PDs write in two of their own, two skills that they think are a high priority for new interns. But it was very obvious that they all mapped into four categories. The first being overwhelmingly at the top of the list was knowing when to ask for help as one of the most important skills that a new intern needs to have and hopefully could develop during fourth year or during the AI. A couple of them grouped together in terms of communication skills. There were a couple that grouped together in terms of time management. I didn't put it on there, but organizational skills was another one. And then there were several that kind of grouped together in just the overall aspect of patient evaluation, developing clinical skills, and really culminating in the idea of being able to recognize sick patients. Then let's take a look at these core EPAs for entering residency, or CEPRs, as some of us in the industry call them. If you take a look at these, and some of you may already be familiar with these, but working with fourth years, it's definitely something that I've taken a close look at quite a bit, and including for the chapter that Sandy and I wrote. The first, the first seven are really things that kind of quickly lend themselves to, well, these are probably things they did in their third year clerkship. Really almost regardless of specialty.
Okay.
Peds
See you
clerkship,
Saturday. Sounds good.
med.
Safe travels.
Somebody's got oh, there, he just muted it. Thanks. So they should have developed some level of independence and moving towards a graduated level of responsibility and taking an H&P, ordering, discussing tests, writing a note in the record, giving an oral presentation, doing an EBM search. The other ones, though, don't really typically have a home in the clerkship, and so it opens the idea that, well, maybe these are things that we can try to address in the acting internship if they're not addressed elsewhere in the curriculum. And one of them in particular that I think lends itself very well to acting internship is the doing handoffs. That's not something that, at least at my school and from my experience, other schools at third years typically do. The collaborating as a member of a team, a big thing here is, especially in the case of discharge planning, that they're working with social workers, nurses. We have care coordinators at our facility, managing post-discharge follow-up appointments and collaborating with teams in that manner. The urgent and emergent care is kind of a luck of the draw kind of a thing, because that might happen if your patient deteriorates and you have a code or a rapid response call. But it opens the door for where cross cover could really make a big impact here, where instead of just covering your 3 to 5 patients, now you're cross covering 3 to 4 teams worth of patients, and increasing the likelihood that with little information, you may have to move to act on their escalating them to a higher level of care. Informed consent, something that they can't really do in paper, but they should really be involved in the discussion of that. General procedures here, AAMC defined it as IV and venipuncture. I used to really kind of sweat because I was trying to find ways to incorporate IV placement into the acting internship, but I found out they get this in anesthesiology. The CPR and bag mask ventilation, though, or what I like to think of as pre-code, as an internal medicine anyway, resident, they won't be intubating anybody. And as an intern, they probably will not be leading a code, or they won't be leading it for long until the true code team arrives. But so I started incorporating CPR and bag mask ventilation and really sort of like pre-code preparation into the simulations that I do. We'll talk about that a little bit later. The last thing is the contributing to a culture of safety and improvement, doing PI projects, RCAs, and things like that. I haven't found a specific way or place to incorporate this into the AI, and I would say maybe I shouldn't. Just a quick word of caution on this about forcing things in, or don't force things in. Several years ago, our college tried to incorporate something that was both interprofessional, med students, nursing students, health association students, etc., and was focused on improvement. They had to work together during their sub-I to do a very limited, or at least the initial steps of a PI project. And it failed miserably. It was just too much time away from that experiential curriculum that they should be experiencing during the AI. And they felt that it was a good project. It was just kind of the wrong place for it, so it went away. So not everything, I guess, necessarily needs to be forced into the AI, but it's something to think about for elsewhere in the fourth year curriculum. So I mentioned that earlier article, the one about now more important than ever. So after that article came out, it was mostly the same authors. They took the old curriculum, internal medicine curriculum, they took what the program directors valued, those 4 tasks, and they took the EPAs and they came out with version 2.0. And I think you might be able to see those highlights. I'm looking on my screen over there. But interestingly, they actually chose the framework of the curriculum. They framed the chapters around those 4 tasks that the program directors identify: knowing when to ask for help, time management skills, recognizing sick patients. And there was another item, just because of the intense focus on safety and burnout, they also added a chapter on wellness. Now, inside the content itself, they also then blended in EPAs, and they blended in core competency issues from ACGME and expanded on those. But I feel like it's interesting. Those topics in that framework, I feel, is fairly universal across specialties, maybe not just internal medicine, is that we want residents who can manage their skills and their tasks, that can communicate, that can recognize sick versus not sick, and that they know when to ask for assistance. And it's just interesting how what doesn't rate very high on scores when program directors are surveyed is medical knowledge. Like, the one thing I think a layperson would just kind of assume, isn't that the most important? But I think most of us know, knowledge, there's a certain assumption that there's a core knowledge there. But in the modern age, ideally, you ask for help, not to your attending, you ask for help from up to date, and you get information from point of care resources that can kind of help you understand antibiotic interactions or renal adjustment of antibiotic doses. And so the medical knowledge part of that becomes surprisingly a little less important. However, so this is a general framework maybe for all residents, but this is an internal medicine curriculum. If you go into the chapter, you will then find it gets a lot more granular and a lot more specific to internal medicine. The chapter on communication, it has specifics for internal medicine notes, internal medicine discharge summaries, internal medicine handoffs. The chapter 3, it's a patient evaluation, recognizing sick versus non-sick. It goes into 10 specific serious can't miss internal medicine conditions in an adult population. Some of that translates over to pediatric, of course, or other populations, but things like fever, altered mental status, chest pain, and it talks about the key recognitions and the key steps for an internal medicine resident. But I didn't want to get into that because I wanted to keep this a little bit more bird's eye view about what could go into curricula elsewhere. I want to go back one last time to that article, not just because I helped contribute to it, but because there really were some very helpful things in there. The now more important than ever. There were some recommendations that didn't make it into a nice, concise table, but I have found very helpful as an AI director. and it goes beyond curriculum and really it gets into some rules or some guidelines for the rotation itself. They're really just kind of the nuts and bolts. And so for me, this is actually the most important slide in the deck. They talked about just some, again, nuts and bolts things that should be built on the clerkships. They were one of the first that I could find that actually started talking about, well, what should duty hours be for a fourth-year med student? Well, if they're going to be an intern, we should at least be mindful and try to adhere to ACGME duty hours. But then more importantly, they started, they identified, look, as with Yale in their statement, the person needs to have the primary responsibility for the patients, which means they have to report to the resident and the attending. They can't co-manage with interns. It's going to erode that independence. They actually talked about caps, and of course that can go up or down as needed. They talked about making sure that they're writing notes in the electronic medical record. Of course, that's gotten greatly helped by the CMS rulings that came out after these initial, or maybe concurrent with these initial statements. They should be putting their own orders in, be involved in all those core transitions. Again, maybe they can't do a code status note at admission, but they should be involved in the code status decision. At transfer, they may not to an ICU. Ideally, they're involved in that process, maybe even signing out that patient using IPASS or SBAR model to sign out that patient to the receiving MICU intern or resident. The cross-cover responsibility is very important. We're going to talk more about that. And then doing a sign out, which is something that a lot of programs don't do. And they mentioned that the evaluation, that rather than have it being on a shelf exam, there are programs out there. When Sandy and I looked at the book chapter a while back, that there's some programs that do have maybe a 20% knowledge check or a small amount from submitting write-ups. But it seems like the majority of programs leave that in the clerkship, and that the fourth year, the main item we're using for grades is based on feedback, evaluations from those who directly observed and worked with the resident, with the sub-Is. Okay, family medicine. They have a great curriculum that is complete. SCFM is, by the way, a Society of Teachers of Family Medicine, and they are firmly and wholly based in the EPAs. They've mapped them according to, you can see on the page, they also map them according to ACGME core competencies and map them against graduated skills according to the RIME model. But you can see maybe they're at the top. They already say, hey, look, we're going to assume that you've already developed some competency in EPAs 1, 5, and 6. By the way, that's gather a history and physical, write a note, and present a patient. And yeah, my expectation of a third year starting a fourth year rotation is they should know how to do that. Sometimes they don't, and we work with them. But they really focused on the other EPAs, which are kind of listed down there below, 2, 3, 4, 7, 8, 9, 10. They said, the last three, if it happens, if there's an opportunity, that's nice. By the way, those last three are informed consent procedures, and that whole thing about being involved in like a PI or a quality improvement initiative may not always be the best place for them in an acting internship. A lot of overlap with internal medicine in terms of the issues that they prioritize through the EPAs. They also just should mention that family medicine specifically said they would like to see it in more than one setting, inpatient plus outpatient, or plus maybe a nursing home or community center, or even home or telehealth. They also felt that grades should be just like internal medicine. Grades should be based on evaluations. And they also highlighted the importance of having an orientation to set up expectations from the very beginning. Pediatrics, this was put together by Sandy, and her co-author was Luba Konopasik, who I believe was also heavily involved with the book. The Alliance of Clinical Education book. And I'm not going to go through all these because they're really just very similar to some of the same language. Those organizations, by the way, they did similar to internal medicine. They took the UME leaders, the Council of Medical Students, Council of Medical Student Education in Pediatrics, and they took the GME leaders, the Association of Pediatric Program Directors, and worked together and came together with these things that are highlighted in yellow are all things that we've heard from the other two specialties. They also had a couple interesting things, and I was thinking, how do you, if we're can expect people to recognize sick versus not sick, how do you teach people to recognize sick versus not sick? And I thought this was really poignant here about, first of all, reevaluating a patient when you receive somebody in handoff, and then looking further when it just doesn't make sense. Continuing to be mindful of them, thinking about them, reassessing them through the course of the day, and having that kind of awareness of what doesn't match here, or what could go wrong, or what is going wrong. So I thought that was a very helpful way to include that sick versus not sick versus lack of another terminology that was highlighted in internal medicine. And from there, the curriculum goes very granular, very specific. It's organized around the core competencies, which many programs are. But you'll see it gets right into some specific conditions, some specific analyses. The authors mentioned, that this could be tailored to different, it's not like everybody uses the same boilerplate set of objective or curriculum and set of objectives, but it could be a starting point that they could fine tune and tailor to their own site. Similar to family medicine, they also felt very comfortable with using evaluations as the core, the key, really the sole element for for grades, and also emphasis on an orientation. Kind of beating the orientation thing into the ground, but that's because I have a slide on it. And probably it's pretty obvious most people would have an orientation. There's not much out there about what needs to be in the orientation other than to define expectations. But I'll tell you what I do and why. So my expectations, my prime directive is to do what the interns do. That includes days off, because that can avoid a lot of heartache and confusion where they think they've got the weekends off, or they think they've got St. Patrick's. Well, that'd be too close to match day, but I think they have some holidays they do get off actually, but homecoming for UF is a holiday for some of the programs here. Trying to get them in the mindset of, as an intern, you get 1 day off a week on average, and you can pool those together wherever you want. But I know I'm probably not alone in this audience and struggling with assumptions about absenteeism from, I had one student who scheduled running the Boston Marathon during the acting internship, and that ended up not being a good idea. So we had to reschedule the internship, the AI, not the Boston Marathon, of course. I tell them I don't track their days off, by the way, it's all in the honor system. And I do try to be mindful, make sure that residents aren't sending all the students home every weekend, which I have seen happen just because I guess they're soft-hearted, but that really kind of erodes their skills and their continuity with their patients and rapport. I tell them to admit like interns. In our case, we have an early call, mid call, late call, which each intern admits at least one patient, sometimes two. And so I tell them, you jump in the team. You also will admit one patient on every admission day. And surprisingly, that still keeps them in that cap of about 3 to 5. I guess the cap is different from an intern because an intern can go up to 10 patients, but that doesn't really track as well. Kind of running this into the ground, but being in charge of notes, orders, and consults. But I make sure that they understand that in the orientation that this is the expectation. I talk to my AIs a lot about the expectation of the resident and the interns that is based on their own classmates and based on the predecessors, the AIs that have come before them, because they really do a really good job. I mean, most of them intensely embrace the mission, take ownership of their patient's care. And so I try to set the expectation in the orientation that that is exactly what their teams are going to expect of them, that they are going to take patients, that they're going to spontaneously offer to take patients. They will enthusiastically see their patients and work on discharges and things like that. And I guess because it can, like with any rotation, it can always be a rotation you can kind of hide in the corner and fly under the radar, but the residents know, they know when somebody's stepping up to the plate and not, and that ultimately can hurt them in evaluations. You kind of hit about co-managing with the resident. I've got, so one thing I'll do with handoff is that I'll have to, I will specifically tell them in orientation, by the way, that if the resident pawns them off onto an intern, they have to contact me immediately. So I can step in and solve that problem. It just creates problems for the interns. It makes problems for the evaluation, the ability to evaluate how effective that AI was on the rotation. The handoff, I talk with them about that they need to do it, and they different tools at different hospitals that they use to do the handoff. I've got a slide on cross cover and I've got a slide on evaluations, but I cover those things during the orientation as well. So cross cover, all right, I've determined that it's highly valued by PDs, but how do you do it? I want to emphasize that cross cover does not mean just admitting people at night. I personally don't really see the value of that. I guess you can develop some autonomy because there's less supervision. You might not have ready access to an attending. Oh, and by the way, I just noticed if anybody's raising their hand, I cannot see that. Wonder if there's a way I can change that. I will not worry about that. I will encourage you to spontaneously speak up if you have a question, and I probably should have clarified that earlier. So yeah, I think the value is really in going from managing 3 to 5 patients to managing 4 or more teams with maybe 60 to 75 patients on them with fairly limited information. We all probably had to do cross cover at some point, and it's tough, it's challenging. So it also increases the likelihood that they're going to see an ERT or a code or someone that needs an elevation of care to step down or ICU. I was looking on the Alliance website and saw some chats. I'm like, oh, that's pretty interesting. I wonder if there's anything about AIs in there. And I came across one from 2022 that some of you may have participated in. And the general sense was that, sure, there's some value to even, learning how to acclimate your body and your expectations and your planning for night shift. But for the most part, what's the expression? The juice isn't worth the squeeze, and also just hard to find a place in the 4th-year curriculum to do that. I think that would be a good next step to actually go to a true night float type system in the specialty of their choice, but that's another topic. I saw for the first time the use of the term twilight shift on this ACE chat, and thought that was brilliant. And that turns out that's exactly what I do. I inherited a program where they did 3 overnights together with the long call team. Well, now long call team doesn't sleep in the hospital anymore. And then I tried to do, they would transition to at the end of the rotation to a night float system. But I sometimes have 10 to 15 AIs across 3 different hospitals, and it just became impossible to schedule. And the feedback was not good. They felt like they weren't getting good learning experience. So I have gone to a twilight system where they'll pick 2 calls of their choice, just make sure that or 2 nights of their choice, make sure there are no other AIs on at around 5 o'clock, tuck their patients in early, align with the cross-cover intern who, depending upon the day in the hospital, might be their own team. So they're actually helping out their own team with cross-cover while they're accepting admissions. Then around 7 o'clock, typically a designated cross-cover person comes in, and they hang out with that person until about 9 or 10 o'clock. They're therefore getting increased likelihood to see a code, to see an RRT or something like that. During the rotation, I think we tend to leave them up to that experiential curriculum. I haven't seen much in terms of in surgical. I did see that there were some certainly cases that they can review in preparation and do simulated cases. But in terms of focused reading, we tend to like them reading on the patients that they're seeing. I have weekly conferences, which for me are almost really more of a check-in with them, so that I can make sure that how many patients are you carrying right now? Are you admitting every day? Are you doing sign out on your patients? Are your notes counting? Is the attending using? So then I can step in real time and kind of help if there's an attending who's not comfortable using fourth year student notes. And then we go through some cross cover scenarios. This is kind of a passion of mine, but in the interest of time, I think I'm just going to suffice it to say that I take them through some case-based common cross cover scenarios 1 week. The second week is purely simulation based with everyone has a role. We practice handoff. There's the student, there's an respiratory therapist and a nurse, there's a supervising attending, an MIC resident. So we practice doing handoffs using the SBAR model or IPASS model, usually SBAR. And one of them is 2 sessions of respiratory. The other one is 2 scenarios with cardiac. So they get comfortable with all the oxygen equipment. I show them how to do EKGs, check them off on bag mask ventilation, and how to push drugs. But more importantly, they leave there comfortable with that terrifying pre-code kind of thing. They learn when to call a code or when to call an ERT and not, hang on and hang on unnecessarily or too long, putting off that call. And also, what do you do? Okay, great, you call it a code, but it takes 2 to 5 minutes for them to show up. So you still got to get the defibrillator out. You still got to do bag mask ventilation. You don't need to intubate. In IM, we're not going to intubate, but we need to do airway management. And so the nice thing is, it's the highest rated thing. I've tried to get rid of doing it numerous times because it's very time consuming. But the evaluations are just through the roof, and they're also motivating when I read about what an impact it's had on them and how comfortable they feel in emergency situations as a result. Again, kind of getting to that core EPA. Some programs do interim feedback. I just kind of skip over that. I find it hard to do logistically. I know this audience is sympathetic, but the students on our 4-week block and the attendings are on a month or half-month block, and the residents are on a staggered 2nd and 17th of the month block. And so, but what I do during the rotation is I ask them, are you getting feedback? Have you met with your resident? Have you met with your attending? And I guess, yeah, so let's talk about evaluation. So this has come up a couple times with the different audience that we've said direct observation is probably the preferred mechanism of evaluation, but just try to get multiple sources. Some programs do resident and attending only. I include the interns specifically. I would recommend do not exclude the interns. Sometimes they're a little skewed on expectations, but man, some of them write just very poignant, share stories about what they've seen the students do with the patient and with family and going above and beyond, and things that I like to incorporate into their summative evaluation. So I feel like we would be unnecessarily excluding some really interesting perspectives by leaving the interns out. Most of them are based on the core competencies. That's what mine is. We have a 9-point Likert scale. I really would like to move more to EPAs and milestones to get away from numeric scales entirely and use milestones that demonstrate increasing in levels of independence. Part of the reason I have problems with this is one of our evaluations, and this is a fairly typical evaluation I'll get from an attending or maybe a cynical resident. This is in the core competency of patient care skills. They gave them all 5s. Medical knowledge 5, PBL 5, interpersonal communication 5. See, really, they're just 5-minute on down the line, and then say, great student, hope he matches here. So there's sometimes just this great amazing disconnect between what we tell people or how we score people and how we reward people and what our words or numbers actually indicate. And so along those lines, I showed you this from Society of Teachers of Family Medicine. In their curriculum, they actually have a sample evaluation, which I find very helpful. It's, as you may remember, it's completely based on the EPAs. They take the first 10 EPAs, they drop out those last 3, and they use milestones rather than numeric scales. You guys, I'm sure, are familiar, but moving up from inconsistently meets expectations, exceeds expectations. But then underneath it, they give anchors. They've got anchors there that say, okay, what are some examples of exceeding expectation versus meeting expectation? And by the way, they recommend that a self-assessment be incorporated into this process as well. The last bullet on that slide before we didn't get to it is grades. And so this whole idea about grades versus pass fail, the UF has a pass fail for the first 2 years, but letter grades for clerkships and mandatory rotations. And about 2 years ago, the curriculum committee switched the acting internship to pass fail. And I was mortified. I was like, what? How can my class be pass fail? That's such an important part of the 4th-year curriculum. This is terrible. But the reality is the grades are pretty binary. I mean, you either acted like an intern or you didn't act like an intern. Overwhelmingly, people do that, motivated by the feedback from their team, motivated by their own initiative and desire to be great doctors. And so overwhelmingly, A's with glowing comments. I might have just 3 or 4 B's or B pluses. I'm trying to think if we did B pluses or A minuses. I think we did B pluses for someone who got there, but it just took a little longer for them to get there. And then once a year, I would have, at least once a year, there would be a C who barely kind of skated by, mostly kind of on professionalism issue, or maybe even an F, or what would usually turn into an incomplete because we would make them repeat. I have made several people over the years, about 1 a year, on average, to repeat the sub-internship. But still kind of binary. You did it, you got it, or you didn't. And that's what the curriculum committee picked up on. So I guess I've kind of gotten over myself and felt more comfortable that the acting internship could be a pass-fail grade. I'm going to go through these kind of quickly because they kind of touch on other subjects. One thing I would mention on that top bullet, sorry, made it go away, is the evaluator. So I see myself as a potential evaluator on the team. I've been asked to write letters for AIs, usually for a combination of things with other letter writers not turning out. But I do get direct observation with them. That's part of the reason I do the simulations. I can see how they think. I can see how they react under pressure. I think the other thing I would mention on there is being prepared to address needs for remediation and professionalism. The thing about the capstone projects, knowing what's in your clerkship, knowing what's in your residency, that's a good example of that is when I found out that the anesthesiology was covering the IV portions in another clerkship. And so therefore I didn't need to do that, which was really kind of a strain and a stress. And it's really kind of icing on the cake, but interacting with the PD for your specialty, find out what her or his expectations are for somebody entering residency. And I have not done this in a while, but used to have great relationships with my other AI directors at my school. And that's something that I would like to do. And we need protected time to do all this. I could give you a number, probably not going to matter. I can say that the clerkship directors of internal medicine said at least a half day per month to just evaluate your program, look at your curriculum, look at the assessments the students are doing of you and of your faculty, and provide that feedback to those faculty. If they don't get it, apply it to your program and your curriculum. 30 minutes per student to evaluate, 30 minutes per student to write a summative eval, 30 minutes per student to, if you're doing some direct observation. So that's, you're getting, depending upon the size of your sub-Is in your program, it's easily, you know, a half day, 4 hours per week. So last slide, I'm not going to read these because you all know how to read, and they're all issues that we've hit directly. Some of the struggles that I've encountered are seeing whether notes count, getting the notes to count. Sometimes it depends on the setting. Sometimes, no joke, sometimes it actually depends on the day of the week about whether a student note counts, just because of the coverage and things like that. For the sub-Is, I'm pretty much about 90% able to get all of their notes to count. You've heard me go on and on about the core EPAs, and I would mention as a reach goal this idea of having an interface with PDs and with your AI directors at your own school, but hey, you know, also in your specialty across the country or through professional organizations like the Alliance for Clinical Education. So I will take questions. Thank you for having me. And if you have a preferred, we use Teams at the VA, and so it's all about the hand raising, and there's like a queue and stuff, but I think we're a pretty calm and professional group, so we can probably just figure it out with folks speaking up. I'm trying to figure out how to get back to the chat. There's probably a chat somewhere.
Yeah, hi, I'm Elise Everett. I'm from the University of Vermont, and we've done some work through APCO and GYN around trying to make the EPAs sort of meet up with the residency milestones. So I was just curious if you had a comment about, you know, since the residency milestones, they're sort of level 1 through 5, and sort of if you make an assumption that level 1 is sort of the minimum performance of a intern on day 1, is there any value in, say, if you're developing a G1 oncology AI to, you know, linking it to those milestones that we see in residency?
Yeah, I think certainly within your own specialty, some of the specialties, especially procedure-based specialties, surgery, the EPAs are written in a way where you're clearly identifying you can do this you can't do it at all. You can do it with direct supervision. You can do it with indirect supervision. You can even teach it, you know, so some of them are written based on that level. And, you know, I would think that most PDs don't want them to come in at 1, you know, can't do it at all. Now, maybe if it's a PGY2 task or a PGY3 task, but looking at the PGY1 tasks, which are variable from specialty to specialty, I think there's definitely some overlap and try to marrying that into what you use as EPAs in your specific acting internship. I'm a little lucky in that the EPAs, the core EPAs for entering residency align very well to internal medicine. Align because there's really nothing in there about procedures other than venipuncture. There's not an expectation that you show up knowing how to do a thoracentesis or a paracentesis. Whereas, of course, a GI fellowship or other programs, you're going to want to be, you don't want to show up day 1 not being able to do those things. And I would think that that also would align pretty well for pediatrics, family medicine, maybe even OBGYN, but probably they're going to need, no, OBGYN, I think OBGYN would be a great example of where you would want more than just the core EPAs that AAMC recommended. You would want to look out at what the GYN, PGY1, milestones and EPAs are, and really try to incorporate that in there if it's an OBGYN, if you have an OBGYN acting internship, that is. Yeah, great idea. Great question. There's a couple things in the chat.
One of the other questions,
Mhm.
yeah, I was going to say, Celeste Newby has a question about what's your protected time for all these sessions. I'm challenged by my clinical schedule and not a lot of help
Yeah.
for sim and didactics for a 12-month course.
There are some sub-I months where I have none. Like right now, there are usually one or two last stragglers who save it to the end right before graduation. And interestingly, twice that's where someone almost had to repeat the sub-I that late in the year. But then there are times when there's 10 to 15. So the evaluations are the things that really get me. My program previously gave me 0.1 protected time, which is 4 hours, and I was pretty happy with that. When it went to pass fail, they reduced all of us to 2 hours protected time. Now, it depends upon how you kind of like slice the pie. So there is an opportunity for me to, for example, become a core, it's new. Some of you have heard ACGME with core faculty requirements for certain specialties that I think may roll out to all specialties soon, but internal medicine identifying core faculty. So maybe these didactics, these simulations that I'm doing, well, really, that could be viewed as more of a core faculty item. So I'm in the it just came hot off the press of the college is trying to find a way to for the didactic portions of things, really kind of like separating what you do for the administration and oversight of the acting internship and what teaching you do in the acting internship, because that teaching that you do, maybe we can get a protected shell or some protected time for that. Either UF even uses educational value units instead of RVUs to get your class recognized. That's something that the college will help buy some of your time out with, or a protected position in one of these core faculty positions, which go up to 0.2. I mean, I won't be able to do 0.2, but even if I got another 0.05 or 0.1 to cover those, because I'm doing 3 to 4 hours of didactics when I meet with them in those sub-I sessions. I guess I kind of answered the question literally in terms of what my protected time is off, but also while I'm unhappy with it, I do have some optimism that at least in my program that we might be able to find other ways for I and other AIs to get what the other AIs from the other programs to get some protected time. The thing that I really, my protected time ends up going to grades, but then what I don't do is go back and look at all the evaluations from the year of the program and try to incorporate, well, where could I make the program better? Where could I make my own assessments, the surveys that we use better? What about the assessments of the faculty who teach on the sub-I as clinical, just on clinical rotations? And I really feel like that's where you kind of need at least a 4-day, a 0.1 block to kind of do that. Otherwise, it kind of ends up being focused on just the bare minimum, which is grades. I was reading some of the other comments. Dr. Dell commented about low-key preference for acting internship, and this in turn is the learning objective for the course. By the end of the rotation, act like an intern. And then there's the thing from Dr. Everett about linking to level 1 residency. There's Celeste Newby. How often do you get a fail in the new system of pass fail? One a year out of about 120. Well, no, let me think about that. 75% of 120. So that's 90. One out of 80 to 90 students, and usually we don't truly fail them. We give them an incomplete, and then they remediate the sub-I, sometimes 2 weeks if we feel like that's all that was necessary. I have seen people fail with the best intentions. I used to have a slide up here about professionalism, but some of them, it's not just laziness, it's not just professionalism. One of the students was homeless, was living in his car. One of the students was dealing with his mom who was Baker acted. One of the students was working frantically to get her PhD final. She got her PhD, but she had to do some sort of poster component and was trying to cram that in. And so just was absent from the team for so much. But that absenteeism is probably one of the major things that factors into a fail, which for us results in a remediation. Point 4 for a clerkship director. An AI director who runs a required course that all students take should have a lot more than 0.1 FT. I agree. A very nice review, nice combo. Oh, thanks. We're pretty much right at time.
We are. Thank you so much for doing this talk today. And
Yeah.
when I get back from this conference, I will get things posted online and send an evaluation out to everybody that joined today. So thank you, everyone.
All right. Have a great day, everyone.
Great, thank you.